Welcome to It's Your Case, presented by VetCT.com. I'm Amy Zalcman, your radiologist on demand for this week. Today we have our final installment of this month's theme of Don't Get Your Gastrointestinal Tract in a Twist. Today's case is a 1.5-year-old female entire standard poodle who began retching and gagging shortly prior to presentation. We have two views for interpretation. We evaluate the gastric silhouette and identify that it is primarily in the right side of the abdominal space. It is gas dilated with heterogeneous soft tissue as well. The fundus is ventrally displaced, which is also inappropriate. A segment of the gastrointestinal tract is gas dilated in the right caudal abdomen and is difficult to differentiate from the caudal margin of the gastric fundus. Therefore, we are unsure if this represents the pyloric antrum or a portion of the colon. The small intestine is globally dilated with gas and distributed along the left lateral body wall and caudally. It is displaced by both the dilated gastric fundus as well as a large soft tissue opaque structure that lies leftward and caudally to the gastric fundus and along the ventral abdomen, which likely represents the splenic silhouette. The renal and urinary bladder silhouettes are poorly visualized in this series. The abdominal serosal contrast is reduced, which is likely due to visceral crowding. However, the presence of wispy soft tissue opacity is not entirely excluded. Our conclusions for this patient generally involve the severe distension of the entirety of the gastrointestinal tract. So let's break this down. There is severe diffuse small intestinal dilation and displacement. This is most consistent with a mesenteric root volvulus. There is marked gastric dilation and abnormal gastric positioning. This may be associated with gastric malpositioning secondary to the mesenteric root volvulus. However, we also need to consider concurrent gastric torsion as well. There is markedly dilated segment of the gastrointestinal tract that is potentially contiguous with the gastric fundus or could represent a portion of the colon. If it represents a portion of the colon, we have to consider the potential for colonic torsion. If it's contiguous with the gastric silhouette, this further supports the differential of gastric malpositioning. We have abnormal splenic positioning, which may be associated with a gastric malpositioning. However, it could also be associated with a mesenteric volvulus as well, or could represent splenic torsion as well. The reduced abdominal serosal contrast could be due to the presence of peritoneal effusion, which could be hemorrhagic or serosanguinous, or could be due to visceral crowding. The findings of this case are most consistent with mesenteric root volvulus, resulting in diffuse small intestinal dilation, and therefore we would consider some degree of vascular compromise. There is gastric malpositioning, which could be secondary to the mass effect by this diffuse change in the small intestine. However, we would also have to consider the potential for gastric torsion. Similarly, colonic torsion and splenic torsion cannot be entirely excluded. Since there is the potential for vascular compromise of some, if not all, of the segments of the gastrointestinal tract, this is a surgical emergency. If more detailed information is required about this patient, computed tomography is probably going to be the most comprehensive evaluation of this abdomen because of the degree of gastric because of the degree of gas dilation throughout the gastrointestinal tract. A barium enema could offer more information about the positioning of the colon. However, any additional diagnostic testing may delay the patient's arrival in the operating suite. Be sure to view the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.